Hello, friends and dear colleagues. Welcome to this session of Young India Intensivist Critical Care Sunday webinars. And today's session is on nosocomial infections. And the speaker is Dr. Neha Gupta. She is a senior ID physician and a consultant at Fortis Gurgaon in ID. And she is very active on the academic circuit and takes regular sessions. She's taken a session for us earlier also that was on gram-positive infections. So without further ado, I'll hand it over to Ma'am.
Thank you so much, Dr. Tapesh. It's a privilege being here. And I've seen the YouTube videos. There are quite good academic lectures which are available. So you can definitely go through the previous sessions as well. I'm Dr. Neha Gupta, Senior Infectious Diseases Physician from the first batch of infectious diseases FNB IT qualified in India. I've been earlier in Medanta for close to 10 years. And now I'm attached as a senior consultant in Fortis Memorial Research Institute. And also, I have been fortunate to start my own infectious diseases clinic, which is NG Swast, the first infectious diseases clinic in the Gurgaon. So we are going to discuss regarding nosocomial infections here. And my presentation today is going to be very simple with a few cases on board. And we are going to take the session based on those cases. So what are nosocomial infections? Well, as per the definition, the nosocomial infections, I need to share my screen, I think, right?
Yeah, please.
Yeah. Yeah. So now it's visible, nosocomial infections. Yeah. So what are nosocomial infections? So nosocomial infections are infections which are acquired in the hospital. Typically, the definition says that infections which are acquired 48 hours after the hospital admission and are not incubating at the time of admission in the hospital. And when we say nosocomial infections, there are few infections which are very commonly which come to our minds, and that is one is the Crbsi, which is catheter-related bloodstream infections. Second is catheter-associated urinary tract infections, hospital-acquired pneumonias or ventilator-associated pneumonias. It can also be surgical site infections. Sometimes if a patient has undergone a prosthetic joint implant-related infections, and also meningitis, that is post-neurosurgical meningitis. So these are the common infections which are encountered, and these are nosocomial infections. And today the focus is going to be on few of these infections. So let's begin with the first case. Okay. So this is a 74-year-old gentleman with peripheral vascular disease. He had atherosclerotic diseases of the abdominal aorta. And in 2013, this is one of the first few cases which I had seen when I started practicing in Medanta. He was in the ICU and he was having septic shock. He had dry gangrene of both the lower limbs and he was on meropenem. Now, because of the gangrene and he was in sepsis, so source control is the most important. He underwent above knee amputation of both the lower limbs, and the amputation pus grew Pseudomonas aeruginosa. Now later, this patient was shifted to colistin and tigecycline based on the susceptibility report which had come. Now, 10 days after the surgery, that is the above knee amputation, he again went into severe hypotension. There was drowse. Clinically, he became drowsy. He developed leukocytosis and the counts just jumped from 14,000 to 27,000 and he had to be started on inotropes. At this point, an infectious diseases reference was sought because he was very sick. So what do you think is the most appropriate next step in this patient? Send the blood cultures from the peripheral percutaneous puncture. Send blood cultures from the central line. Send blood cultures from both the central line, that is the CBC, and peripheral percutaneous puncture, or none of the above. So this gentleman is in the ICU. He is having a central line. He's also on broad spectrum antibiotics. He has a recent surgery which has been done. So what do you think is the most important? So here, definitely, I think most of us will think that we need to send blood cultures, and we need to send blood cultures from both the central line as well as from the peripheral line together. But more than that, what is important is to clinically examine and clinically ascertain that what is the site of infection and why exactly this person is developing suddenly this catastrophic hypotension, severe infection. So here we'll discuss one by one all of this. First is definitely we need to send blood cultures from the central as well as the peripheral percutaneous puncture, but not, we should never send cultures only from the peripheral puncture. Why? Because it can, if it suppose grows a bacteria, it can also represent contamination or the skin colonizer, and it may not be always representative of the Crbsi. So it's important to send cultures from both the central line as well as from the peripheral cultures. Now coming to sending the blood cultures only from the central lines. Why this is also not right? Because it can represent a catheter colonization. And very important is whenever we want to diagnose a CRBSI, it's important to send cultures from both the central as well as the peripheral percutaneous puncture. And simultaneous sending the cultures has clinical significance because we need to look at the time to positivity from the central line as well as from the peripheral percutaneous puncture. If the bacteria which is growing from the central line is growing 2 hours earlier than the bacteria which is growing from the peripheral line, and both the bacteria are the same, that is, the differential time to positivity is more than 2 hours, then this is suggestive of CRBSI, that is catheter related bloodstream infection, with a very good sensitivity as well as specificity. The specificity is close to 94%. Also, because we are growing the same bacteria from the central as well as from the peripheral percutaneous puncture, it kind of negates the chances of colonization, which otherwise would be if we are sending cultures only from the central line or only from the percutaneous puncture. So that is why cultures simultaneously should be sent. This also brings us to the discussion of the blood cultures and their clinical importance. So what is the clinical importance? And when we say we need to send blood cultures, how much should be drawn from the blood culture? So there are definitely several studies which have been done. And in fact, we have papers which was published in 2007, that is close to 17 years earlier, almost 2 decades earlier. And they all mentioned that if we send just one bottle of blood culture, the sensitivity is only 10 to 15%. That is, the chances of isolating a bacteria is only 10 to 15%. And each blood culture bottle at least should have 8 to 10 ml of blood. So if we send that, then it is only 10 to 15%. However, suppose we just increase the volume from one bottle to one set. One set is 2 bottles. So if we increase it to one set, then the chances of isolating the bacteria just jumps from 15% to 65%. So we are going to have more and more chances of detecting the bug in our diagnostics, which will definitely help us in our clinical management. If we increase the one set to 2 sets, then the sensitivity of isolating the bug increases from 65 to 80%. And with 3 sets, it becomes 95%. So if suppose there is a patient who is in the ICU and develops a sudden onset leukocytosis, then the most probable chances is of a CRBSI, and even if it's something else like a VAP or a CAUTI, then also when we are drawing the blood culture, send it from both from the central line as well as the peripheral line, and send one set at least from the central line, that is 2 bottles from the central line and 2 bottles again from the peripheral percutaneous puncture. Ideally, 3 will be definitely preferred. So all the studies, they have mentioned that the most important variable that affects the blood culture is the volume of the blood which is cultured. It doesn't matter whether the patient is having fever or not, It doesn't matter, any other parameter doesn't really matter so much. It is the volume which matters the most. So now with this background that the patient was in sepsis, he was in severe infection having leukocytosis. So we really needed to determine what is the site of infection. This patient has just undergone a lower limb amputation above knee. So we looked at the surgical site. The surgical site was absolutely clean, as you can see here, clean without any pus. This patient was in the ICU and he had the central line in place. So this central line, if you see, it was in place for close to 17 days. And when we just removed the dressing over here, it had this pus at the exit site. So this is suggestive of a probable CRBSI because there is an exit site pus. And I still remember it was 6 o'clock in the evening. We were just about to go home and I had this reference. But what is important is this patient, rather than just sending the swab or ordering it, we really made an effort to take the gram stain, went to the lab, look at the we made the gram stain there, waited for it, and within 5 minutes we had the result. This is what we saw here. So this was the budding yeast which was seen on the gram stain. So this patient had most probably, this is from the exit side, the blood culture is still awaited. Most probably this patient had a line related bloodstream infection because of candida. So this was a candidemia resulting in a CRBSI. Now with this, let's go to the management. So which of the following is the most correct statement in this particular patient? So start fluconazole 800 milligrams stat followed by 400 milligrams daily. Start with an echinocandin. Treatment duration in this particular patient will be close to 14 days of the antifungal therapy. CVC removal is not really needed and ophthalmic examination is not recommended. So what do you think we should start in this patient? Yes, indeed, it will be echinocandins because fluconazole, as we all know, has to be used in case of a mild illness or if the chance of resistant fungi is less, or if the patient has not had any prior azole exposure. That's when we can use fluconazole. But in this patient, he is having hypotension. He's very sick. So in case of moderate and severe illness, the recommendation is to start with an echinocandin. And more importantly, if suppose there is a prior azole exposure, and nowadays we are seeing very resistant candida species like the oris. So in that case, the preferable drug obviously will be an echinocandin to start with. Coming to how long should we continue with echinocandins? It depends upon the blood culture negativity. So when we start the antifungal therapy, we need to repeat the blood cultures at 24 to 48 hours. Preferably in the clinical practice, we do it at 48 hours. And if that particular blood culture is negative, then we count that particular day as day 1. So the duration of therapy is 14 days after the first negative blood culture. It is not from the day when we have started the echinocandins, but from the day of first negative blood culture. And coming to the central line removal, yes, source control in an infectious diseases is always necessary. Whatever is the source, that needs to be controlled. So central line, especially in a non-neutropenic patient, because that's going to be the source for the candidemia, needs to be removed until and unless there are no other venous access in very rare circumstances. But here, if suppose there is hypotension, then of course we have to remove it. And also it needs to be removed in case there is an exit site infection. And of course, all patients with candidemia should undergo ophthalmic examination to rule out candida endophthalmitis, because the treatment duration is completely different, which requires treatment for close to 3 months. In patients who are neutropenic, they should undergo ophthalmic examination when the neutropenia has recovered. And patients who are non-neutropenic, definitely they need to undergo ophthalmic examination, preferably within the first week. Now, this is regarding the management of candidemia, which was causing the CRPSI. But whenever we have a candida in the blood culture, we need to find out what else can we offer to the patient. So let's look back at the culture report. So the culture report had Pseudomonas aeruginosa here. And when we look at the culture report, so let's look at the susceptibility. So you look at the third generation cephalosporins, which is ceftazidime, which is susceptible. Ciprofloxacin is also susceptible here. And look at the tick marks which have been done. So in our minds, it's always we look at the broader spectrum antibiotic. We look at colistin, which was ticked also. And of course, we had the meropenem, which was ticked. But we need to choose the drug or the antibiotic which has got the narrowest spectrum so as to avoid any collateral damage. So here, instead of the broad spectrum colistin and meropenem, it is better to use ceftazidime or ciprofloxacin. That's very important. So here, of course, I have already answered this particular question, but let's just go through it. So which of the following is the most appropriate antibiotic? Colistin and tigecycline, which this patient was on already, colistin and meropenem. Should it be ciprofloxacin and meropenem? Because both of them had been sensitive or susceptible rather, and or just ciprofloxacin for 5 days. So here the answer is actually ciprofloxacin for 5 days, because when we look at colistin and tigecycline, colistin is susceptible, but it is a very high-end spectrum antibiotic. What about tigecycline? Tigecycline does not even cover Pseudomonas. It is intrinsically resistant to the tigecycline. So this combination is not to be preferred or not to be used in this particular patient. Coming to colistin and meropenem, again, two susceptible antibiotics, but not as per the antimicrobial stewardship. There will be a lot of collateral damage. Cipro and Miro definitely are susceptible, but why do we need a combination therapy when we have the DST which is available? So when DST is available, then only ciprofloxacin can be used. Cipro is an excellent drug for the susceptible Pseudomonas or the gram negatives. And if the source control is done, like when a full amputation has been done, then the requirement for antibiotic is just for 5 days and not even for a longer duration. So here when we have Pseudomonas will be intrinsically resistant to TMP-SMX as well as to the tetracyclines as well as to the ampicillin. And we must always remember this particular table which briefly summarizes the various antibiotics which do not cover certain organisms. So for example, ampicillin will not have activity against Klebsiella or even Proteus. We have cloxacillin, which has no activity against the enterococci. Cloxacillin is a drug of choice for the Staph aureus. Third generation cephalosporins like the ceftriaxone have no activity against enterococci. So these are not covered. So if a patient is in the ICU on ceftriaxone and having constipation, remember that it could be an enterococci bacteremia rather than a resistant or gram-negative bug. So here, the other thing is, again, Pseudomonas are not really covered by ceftriaxone. This for Pseudomonas, it's ceftazidime which has more activity. We have Listeria monocytogenes and C. difficile, which are again not covered by the ceftriaxone. Ceftazidime, cefixime, ciprofloxacin do not have much activity against staphylococci. Similarly, when we have imipenem, imipenem has no activity against the Stenotrophomonas. And for carbapenems, again, when we look at it, it is basically so for carbapenems have no activity against the MRSA and the enterococci as well as the C. difficile. Enterococci may be covered by the imipenem. And for colistin, which is like the backbone of treating nosocomial infections in the ICU, there are certain bacteria which are not covered, like the gram positives, anaerobes, and among the gram negatives, it's Proteus, Providentia, Morganella morgagni, Serratia, Burkholderia, Salmonella, which are not covered. Yeah. So this I have just covered that, of course, role of combination therapy for Pseudomonas is really not needed once we have the susceptible results. And it is based on several studies which show that the probability of survival is in fact the same when a combination therapy is given. as compared to the monotherapy. Correct. So now with this, we move on to the another case. This is a 56-year-old gentleman, and post he underwent a CABG. Now post the CABG on day 5, this patient had a sudden onset leukocytosis with the counts just jumping to 29,000, hypotension, and he had a cardiac arrest. He had to be revived with a CPR, and there was a central line in place. He had in other invasive devices like the urinary catheter, and of course, he had to be put on invasive ventilation. His creatinine just jumped to 1.1 and was 1.1. His baseline was also around 0.9 or 1. Chest X-ray was done as a part of the workup, and that did not show any new infiltrates. This patient was on cefoperazone sulbactam 1.5 grams 12 hourly. So now with this background, which of the following is not so appropriate? Send blood cultures from the central line and peripheral percutaneous puncture. Remove the central line. Remove the central line. Initiate on carbapenem and teicoplanin. None of the above. So the answer is actually initiating on carbapenem and teicoplanin. It's okay, definitely, whenever there's a patient who is having an acute onset fever in the ICU, the first step is to localize what is the site of infection. And in this patient who is in the ICU having a sudden onset, again, fever, and of course, hypotension, there are several possibilities like the ventilator-associated pneumonia, Crbsi's surgical site infection because he has recently undergone a CABG, and of course, because of the urinary catheter in place, a catheter-associated UTI. But there are certain factors which favor a particular diagnosis and are against the rest of them. So let's look at VAP. Well, in this particular patient, this was a very catastrophic event. Usually, VAP will not result in so much sudden deterioration to this extent. And besides this, we also need to look at the other associated symptoms and the signs. So in this particular patient, there was no increase in secretions, and besides, there was no radiological evidence of any consolidation per se. He also had Crbsi. Was the other differential? Yes, sudden onset leukocytosis, hypotension, central line. It is possible to have a line-related infection. Coming to surgical site infections, that is also a differential, but the wound was very healthy. There was no active discharge from there. And what about the catheter associated UTI? Yes, that is also to be considered. But in this particular patient, the kidney function was absolutely normal. And subsequently, the ultrasound which was done, which was normal as well. So there are certain other non-infective causes also which need to be considered, like a pulmonary thromboembolism. But of course, we are doing this infectious diseases round. So these are the infective causes which are the most common differentials. Now in this particular patient, as this patient had the likelihood was definitely a CRBSI, and this patient was on cefoperazone sulbactam, which is a BL-BRI combination, and at a dose of 1.5 grams 12 hourly. The usual dose would be 3 grams 12 hourly, and that's when he had developed infection. So the likely causes are the resistant gram negatives and carbapenem resistant gram negative bacteria. So here we immediately had started this patient on polymixin B combination therapy, and subsequently, while we were awaiting for the cultures, this patient the line was also removed because the source control had to be done. So source control and the appropriate antibiotic therapy was initiated. Now here, subsequently, the blood culture from the central line as well as from the peripheral line, both grew this Klebsiella pneumoniae. As we can see, a Klebsiella pneumoniae was isolated both from the central as well as the peripheral line with a differential time to positivity of more than 12 hours. Remember, 2 hours is the DTP required for the CRBSI diagnosis. And here we had 12 hours. So the central line grew 12 hours earlier than the peripheral culture. and it was a carbapenem resistant. So you have Miro as well as IMI, both were resistant, and the colistin was susceptible. This is an old report. Of course, nowadays we won't find a S in colistin because of the change in the guidelines of susceptibility. We will find only intermediate. So here, the other report definitely had colistin susceptible, and fosfomycin also reported. And of course, it was a carbapenem resistant one only. So this was again a case of catheter-related bloodstream infection with a carbapenem-resistant Klebsiella pneumoniae. And whenever there is a patient who has got a central line or any intravascular catheters, they always pose risk for the bloodstream infections. And 40% of the primary bloodstream infections in the ICU are associated with the line-related infections. The impact on CRBSI is that it results in prolonged hospitalization and of course increases the cost to the healthcare. And there is also an increased mortality to 5 to perhaps 7% as well. There are several types of catheters and each one of them increase the risk of CRBSI. The least is with the peripheral cannula and maximum is of course with the is associated with the central lines, and femoral catheters are associated with higher risk as compared to the jugular catheters. And that is why ideally femoral catheters should be avoided. And PICC line again are associated with risk of infections, but much lesser as compared to the central venous catheters. Short-term catheters and long-term catheters. Short-term catheters are less than 14 days. Long-term catheters are more than 14 days, and long-term catheters are associated with a higher risk as compared to the short-term catheters. Now, infections of the intravascular devices. These can happen because of either associated contamination of the catheter hub, or it can happen from the contamination of the infusate or contamination of the device prior to the insertion. But most commonly, the catheter hub contamination is the source for the CRBSI. And when we look at the profile of the catheter-related bloodstream infections or bloodstream infections per se, this is one of the data from the leading tertiary care centers. And as we can see here, in 1 year, the blood culture positivity was close to 664. And the most common organism was positive was the cons, which is 26%. This was followed by Klebsiella pneumoniae, which was 14%, and subsequently we have E. coli at 12% and Candida as well at 12%. This was followed by certain other bacteria like the Pseudomonas at 4 and Acinetobacter 5, and Staphylococcus aureus gram-positive at 4%, and another gram-positive infection, Enterococcus, at 6%. Now, I will just break this down. Why is cons at 26% a problem? Because when we talk about cons isolation, as per the international standards, ideally the percentage of isolation of cons should be just between 2 to 3%. And if it is more than this, then either it indicates contamination, that is, the samples are not being collected properly, or it indicates line-related infections if there is a large ICU with multiple central lines being used. So in any case, cons at a rate of more than 2 to 3% is a problem. So we need to check whether we are collecting the samples properly or not, because if it is not being properly collected and we are saying contamination, we are getting this report of GPC positive, then unnecessarily gram-positive antibiotics will be initiated. On the contrary, if suppose cons is being isolated, and so we need to relook at our infection control policies for the CRBSI, that is the CRBSI bundle needs to be looked into again. And another organism which is of significant importance beside the gram negatives, we all know, we all talk about it, that they result in there is a of course, we face GNB minase in the ICUs, but enterococcus is again a significant problem, especially if the patient is on meropenem or on ceftriaxone, because that's when the other bacteria are completely killed, but enterococcus becomes a predominant pathogen. And in case the patient is having bowels are not open, there is constipation, then the bacteria from the gut will translocate and produce infections, and they can also colonize, especially the VRE, which is so difficult and is contagious. Then it can colonize the external body surface area as well as the lined invasive catheters and result in subsequent infection and the bloodstream infections. When we talk about the gram-negative infections, this is the state of world's antibiotics. We all are aware of this, that it's India, which is the hotspot for the carbapenem-resistant bugs. And like this patient who had a resistant gram-negative infection with Klebsiella pneumonia, which was carbapenem-resistant, the question is then how do we treat such patients, right? So in this patient, how do we treat? Should we use a combination of colistin with meropenem? Should it be polymixin B? Should it be poly B with meropenem? Or we need some more information for treating this carbapenem resistant Klebsiella pneumoniae? So just remember that in case the patient is on a BLBI combination and is developing a superadded or a breakthrough infection, then the possible organisms are going to be resistant gram-negative, carbapenem resistant gram-negative, enterococci, and the third one is Candida. These need to be kept in mind. So we need to look at the other possibilities of how do we treat besides polymixin B and meropenem. We need to know the susceptibility for fosfomycin as well. And of course, there is some other option like Cas-Avi, ceftazidime, avibactam susceptibility, which also needs to be known because this is an option which is available with us now. So here I will just like to discuss regarding the PK/PD of the colistin and the polymyxins. So we all are aware that CMS is colistin methane sulfate, which is the prodrug of colistin. And here basically 1 million unit is equal to 80 milligrams, and which is equivalent to 30 milligrams of the colistin base activity. Now the PKPD of colistin is the parameter is the AUC by MIC here, and the free AUC by MIC of 12 or a AUC by MIC of 24 is associated with a 1 log kill. Now this can be achieved when we have a target colistin steady state average of 2, and which is usually this particular steady state average of 2 generates a AUC of 48, and this corresponds to the AUC by MIC of 24 when the MIC of the organism is less than 2. Now, usually when we use colistin, we give it as a loading dose and then subsequently at a maintenance dose. Loading dose is irrespective of the renal function, which is weight by 7.5. And maintenance dose is creatinine by 10 plus 2, which is a simple formula to calculate the maintenance dose. Now, in critically ill patients, like there are several changes which occur. So there is an increase in the, there are leaky capillaries, there is alteration in the protein bindings, increased cardiac output. All of this result in an augmented renal clearance. And during this, there are several factors which affect the concentration of antibiotics, especially the hydrophilic antibiotics, as well as the concentration of the colistin or the polymyxin also gets affected. So this is one of the PKPD models which was performed, and here it shows that the probability of target attainment of colistin of the steady state average of 2, as we can see here, this is the steady state average of 2, it depends upon the creatinine clearance. And as the creatinine clearance increases, that when it increases beyond 80, the probability of attaining this steady state average of 2 drastically decreases down. And especially when the creatinine clearance is more than 10, which occurs in patients with young individuals, especially in case of early sepsis, then the probability of target attainment of this colistin steady state average is only 18%. And in patients with profound neutropenia, this PKPD index parameter is in fact 1.5 to 2 times higher. So we need a higher steady state average to achieve or a higher dosing to achieve this particular steady state average. So because of this problems associated with the in achieving the steady state average of colistin, especially when there is an augmented renal clearance, there was a need to explore the other antibiotics, and that's when polymixin B definitely became one of the again important antibiotics which we started using for treating the nosocomial infections. So here this is polymixin B, which is an active agent, which is as compared to the CMS, which was a prodrug. And we all know that CMS gets converted into colistin, which is an active agent. And this conversion itself takes around 4 to 5 hours. And plus the conversion is very variable. It keeps on varying from brand to brand as well as from batch to batch. And subsequently, the colistin, active colistin, has got a non-renal clearance, but it's the CMS, which is the prodrug, which is renally cleared. So 60 to 70% is renally excreted. So whenever there is renal dysfunction, the CMS gets accumulated and further causes the nephrotoxicity. Whereas with polymixin B, which is an active agent, and there is no need for conversion to an active to another I mean, it is an active agent. So, and also the interpatient variability, as we see across the various wide range of renal function, is not much. So the chances of achieving an adequate concentration is much higher with the polymixin. The other difference of polymixin B as compared to the polymixin E is that it gets extensively absorbed from the renal tubules. So as a result of this, the concentration which is there in the urine is not much, and hence it is very important for us clinicians to differentiate whether it's a CRBSI or a UTI, because if we are choosing polymixin B, it will not work for the UTI. It will definitely work for the CRBSI, but not for the UTI. And so it becomes very important to differentiate between these two particular nosocomial infections. This is a table which briefly summarizes between the CMS as well as the polymixin B. CMS is a prodrug. It has to be administered over 30 minutes, whereas polymixin B is an active agent, but requires a longer infusion. Otherwise, it can result in sometimes fluid overload as well. The infusion related toxicities is much more with the polymixin B. That is why slower infusion is recommended. Although the nephrotoxicity of polymixin B is probably half of the CMS, but it is not devoid of nephrotoxicity. Nephrotoxicity can still happen, which is documented close to 20% of the 20% of the cases. It is associated with more significant neurotoxicity, and also fluid overload is a problem. Does not have urinary levels, cannot be used for the UTI or for even for the catheter associated UTI. We have polymixin B now, which is being used as both inhalational therapy, can be given for the VAP as well. But usually we are using the CMS, and these are the few basic differences between the CMS as well as the polymixin.
So, Neha, what is this fluid overload? This is the amount of volume used to administer or what?
Yeah, correct. Because we anyways need it has to be given in 200 ml, 100 to 200 ml. So that again adds to the fluid overload as well. And especially in patients who have got LV dysfunction, this is a problem. Like in patients who had CLD or even cardiac failure, this polymixin B can result in a because we need to infuse it, and plus we need to infuse it over a little longer infusion time. Okay, so now we use polymixin B as definitely one of the backbones for the treatment of carbapenem resistant gram negative infections. But whether we should use it as a combination or as a monotherapy. So this is one of the important studies which was done regarding the effect of appropriate combination therapy on mortality of patients with bloodstream infections due to carbapenemase producing enterobacteriaceae. This was an increment study, which was a retrospective cohort study, and which showed that when there was a low mortality score, the difference between the combination therapy as well as the monotherapy was not significant. But in patients who were much more sicker, patients who were in the ICU and with a high mortality score between 8 to 15, monotherapy was associated with a lower survival rate as compared to the combination therapy. So a combination therapy was preferred with polymyxins. Now, when we talk about a combination of poly B and meropenem, how and when should we use it? So, of course, we are all evolving with then more and more data which keeps on coming. So we were earlier using 1 gram 8 hourly of meropenem. Then came the concept of using high dose meropenem over prolonged infusions for 8 hours. This was based on this study from DICOS. But now we know that, of course, in critically ill patients, for maximum benefit, the free drug concentration should be in fact 4 times above the MIC, and it should be for the, and ideally for the entire 100% of the dosing interval. So when we look at 2 grams prolonged infusion 8 hourly, the chances or the probability of achieving this 50% time above MIC is just close to 50% when the MIC is around 16. Ideally, the combination of 2 grams 8 hourly is, or high dose meropenem is more useful when the MIC is between 4 to 8, or it can be used up till 16 as well. But in our current scenario, where most of the bugs and the Vitek or the automatic system just tells us that see the MIC is more than 16, this particular combination therapy may not be beneficial. So we need to look at other treatment options, like if there is a antibiotic like fosfomycin which is susceptible, or if there is another antibiotic like a BL-BLI combination which is susceptible or available. So when we look at fosfomycin susceptibility, remember this particular patient had 2 culture reports. He had one from the blood culture from the central line, another blood culture from the peripheral percutaneous puncture. And when you look at the reports, the first one did not mention about fosfomycin. The second one mentioned about fosfomycin. So it's important always to look at all the culture reports, whatever possible as well, for just looking at the susceptibility also. Fosfomycin is a good drug. It's a cidal agent, has got time above MIC as its PK/PD. So more frequent dosing needs to be given. And of course, it is active. It has activity against most of the gram negatives, but does not cover Acinetobacter baumannii, bacteroids, and Listeria monocytogenes. So for probably like nosocomial infections where the Acinetobacter is a predominant pathogen, then empirically fosfomycin cannot be used alone. Anyways, alone should not be used because it's a drug which acquires resistance. So it should be used always as a combination therapy. It's a drug which achieves very good urinary levels, and the dose is usually 16 to 24 grams per day. Because of the good urinary levels requires renal dose modifications with creatinine clearance of less than 40. There are few adverse effects associated with it, which is a fluid overload, sodium, which is high, hyponatremia, hypokalemia, as well as sometimes diarrhea can also be seen with the IV fosfomycin. It's cidal because it acts on the cell wall. It's a murin A inhibitor. Besides fosfomycin, nowadays we are using less and less fosfomycin because of the availability of the newer beta-lactams, especially the novel BL-BLI combinations or inhibitors. Like we have the ceftazidime avibactam, which is available, and this particular table briefly summarizes the activity of the beta-lactam ceftazidime avibactam and compares it with the other BL-BLI combinations. So when we say ceftriaxone, like ESBLs, So the ESBLs obviously is resistant to third generation cephalosporins. Ceftriaxone will not have any activity against the resistant ones, resistant ESBLs or even NDMs, etc. But when we look at the ceftazidime avibactam will have activity against the ESBLs. But more importantly, it is for the CREs in our current scenario. And we need to know whether the mechanism of resistance is OXA48 or it's NDM, because ceftazidime avibactam inhibits OXA48 but does not inhibit the New Delhi metallo-beta-lactamases. There are certain other BLB-like combinations like estronam, avibactam, which will inhibit NDMs as well, and also cefidericol, which will have activity against the NDMs, as well as probably against the Pseudomonas as well as the Acinetobacter. So if in the ICU we have a bacteria which is isolated, especially it is a gram-negative Enterobacteriaceae, to know the mechanism of resistance, we can do or check, we can perform this expert Carba-R, which is the CIFID expert, and it tells us regarding the 5 common mechanism of resistance which are available. So it tells us regarding the KPC, NDM, VIM, OXA48 and the IM. And as we can see here, the OXA48, if detected, will just light up. And as such, this particular process, if it's an in-house assay, will take just 2 to 4 hours. That's it. It's a very rapid assay and tells us immediately. And this gives us typically very good information that we can use a CASAV or not. We can also, ideally, we should be performing the susceptibility, the phenotypic susceptibility with the CAS-AVI-E strips here. And as we can see here, this is a susceptible one with a MIC at 1. In India, especially when we look at the susceptibility of or the mechanism of resistance of the carbapenem-resistant Klebsiella pneumoniae from the bloodstream infections, we do have OXA48 to the tune of 13%. And in certain centers, definitely a higher OXA48 is also being isolated. And CAS-AVI is a particular, it's ceftazidime avibactam, which works against the KPC as well as the OXA48. And it has got renal clearance and hence requires renal dose modification. And normal dose, as we know, is 2.5 grams 8 hourly. Depending upon the whether it's a UTI or it is a bacteremia, the duration of antibiotic therapy will depend. So this is one of just the algorithms of gram-negative infections management in the nosocomial infection. Suppose you have a GNB which is isolated from the nosocomial infection, then we can do an expert Carba-R. If suppose it detects the carbapenem resistance, OXA48 only ceftazidime avibactam. If it is a combination of OXA48 with NDM, then we can go for polymixin combination therapy or a combination of ceftazidime avibactam with astronam. So when we talk about Crbsis, it's very important to focus on the infection control bundles, which is the Crbsi bundles. And here we have both, we have insertion bundles, the maintenance bundle, as well as the removal bundle, which have to be focused on. And when we talk about insertion bundle, most importantly, we need to see whether we need the central line or not. So this is a patient who has got multiple, central line and also at the same time peripheral cannula. So we need to really look at it whether central line is needed on a daily basis or not. Coming to insertion bundle, it's very important to maintain a strict hand hygiene. And of course, we need to select the optimal catheter site. As I mentioned, that femoral catheters have a higher chances of infection as compared to the jugular catheters. So they, or the subclavian. So subclavian should be preferred as compared to the femoral catheter sites. And it should be done under maximum barrier precautions. And a full body drape is ideally recommended from head to toe. The nurse, complete scrub nurse should also be is also is required. And with this, of course, maintenance of the sterile sterile field is very, very important during the insertion, and there's no need to give any prophylactic antibiotic during the insertion. Now, points to remember for the skin antisepsis is that we must use 2% chlorhexidine skin preparation before the insertion of the catheter, and it should be given a proper dry time as well. So the preparation should be at least for 30 seconds, and it should have a dry time for at least 30 seconds further. For certain wet sites like the femoral or the groin, the preparation should be done at least for 2 minutes, followed by 1 minute dry time, and ensure that the solution dries completely before attempting to insert the central line. And after the insertion, a chlorhexidine biopatch can also be used, which has been shown to decrease the incidence of the CRBSI. We should choose minimum lumens, and minimal collections or connections should be chosen. After the lumen insertion, it's very important that there should be an occlusive sterile dressing per se. And of course, we need to look at the chest x-ray to see whether the tip of the catheter is in place or not. And after the verification of all of these basic things, it's important that we never connect the previously used IV tubing to the new central venous access line. Maintenance bundles are very, very important. It should be a daily inspection as well as monitoring. Dressing should be visualized. A common mistake which happens is that we have the dressing in place and then a opaque dressing is placed at the exit side. So that makes it very difficult to examine the exit side daily. It should be, the exit site needs to be checked on a daily basis, and the dressing which is applied or the labeling which is done should also be done in such a manner that the exit site is visible. And we need to look at the dressing for any visible soiling. Regular dressing, especially the gauze dressings, need to be dressed every 2 days, and transparent dressings need to be done every 7 days. Sterile gloves should be used for changing the dressing, and cleansing agent should be chlorhexidine. And even the nurses, they should be told or emphasized that they have to use sterile gloves before they just touch the central line. Cleaning the hub is very, very important because this is the most common source for the CRBSI. So it has to be cleaned. Any soiling, any blood at the hub site is a risk factor for the bugs to grow and produce subsequent invasion and bloodstream infection. Square alcohol wipes for cleaning the hub can be used, and a three-way with caps will be preferred rather than that should be preferred. Coming to the administration sets, these are also very important. So administration sets needs to be replaced, and they should be replaced no more frequently at 72 hours until a Crbsi is suspected. And daily check of the line is extremely important. It should be every day, and we must ask whether the patient still needs a line. If yes, can we use a less risky line? Can we change to a peripheral cannula and remove the central line or not? So there are certain other interventions which can be used to reduce the complications, like we can use antimicrobial impregnated catheters to reduce the risk as well as the cost when the Crbsi rate is more than 2%. And of course, there is no need to routinely change the catheters per se. There are certain other interventions like using Posiflush, etc. Chlorhexidine-based catheters, mini-bag plus, and collapsible bags, which can also be used for prevention or reducing the risk of CRBSI. There are certain definitions which are being used for whenever we want to monitor the CRBSI rates. That includes the central Crbsi rate per 1,000 central line days, and also the central line utilization ratios. At the same time, it's very important to give optimal care for the IV injection ports as well. And all the central line ports should be capped when they are not in use, and prior to accessing the port, clean it with 70% alcohol and allow to air dry before accessing the system. This is very, very important. Coming to the hemodialysis catheters, the hemodialysis catheters should not be used for blood drawing or for applications other than the hemodialysis, except during the dialysis or during any emergency circumstances, and use povidone iodine antiseptic ointment at the hemodialysis catheter site after the catheter insertion, as well as at the end of each dialysis session unless contraindicated. There's also some chlorhexidine alert, that is in case of infants less than 2 months of age or in anybody who has got some chlorhexidine sensitivity or allergy. These can be replaced, and we can use 10% povidone iodine or 70% alcohol as an alternative skin preparation. Now with this, we will move on to the next nosocomial infection, which is a catheter-associated UTI. So initially, the catheter-associated UTI, the Foley's catheter was in fact introduced in 1927. Initially, it was an open drainage, and later on, a closed drainage system was brought into clinical practice. This closed drainage system is associated also with bacteriuria, and at the end of 30, close to 4 weeks or day 30, close to 95% of the patients, if they are catheterized, will have some bacteria or the other growing from the catheter. So it's very important that we, if a patient is, we need to differentiate whether the patient is having a colonization or asymptomatic bacteriuria, catheter associated, or it's a catheter associated UTI. And for example, we'll move on to this particular case. This is a 54-year-old lady who had difficult endocarditis. It was an aspergillus endocarditis, and she had a mitral valve replacement done. And subsequently, she was in the ICU. She was catheterized and received meropenem as well. Now, 2 days subsequently, the catheter was removed. And 2 days after the catheter was removed, this patient had this increased frequency as well as the urgency of urine. There was no history of fever, but this urine culture grew this Proteus mirabilis. And as we can see here, this was susceptible, this was resistant to third generation cephalosporins, but susceptible to the BL-villi combinations. And so this was an ESBN. And this was a catheter with a significant colony count of 10 to the power of 5. So this was a catheter associated UTI with Proteus mirabilis. And important thing is that this has happened 2 days after the removal of the catheter. So this is a common mistake which happens is not all the CA UTIs happen when the patient is catheterized. It's when the catheter is removed, the risk of infection also increases. So when the definition of CA UTI is used, even patients who develop UTI within 2 days after the removal of catheters should be included. And these are the patients who are actually missed because they are either in the OPD or perhaps in the ward. So what is catheter associated bacteriuria? There is, with every patient who is having an invasive device or is having a catheter in place, there is a 5% incidence of bacteriuria per day of catheterization. So which means that at the end of 7 days, 25% of the patients who have a catheter will have a positive urine culture. And if the catheter is in place for 30 days, then almost 100% of the patients are going to have a positive urine culture if we take the sample from the urinary catheter. Now that does not mean that the patient has to be put on some antibiotics. It will depend upon the symptoms of the patient. If the patient is asymptomatic, then this is a catheter associated asymptomatic bacteriuria rather than a catheter associated urinary tract infection, and requires no treatment. At the most, we can change the catheter. So patients who develop catheter associated bacteriuria, only 20% of them may become symptomatic, and only 4% of them may be bacteremic. So the risk of the risk of infection or bacteremia following a bacteriuria is less. So that is why patients with bacteriuria or catheter associated bacteriuria need not be given prophylactic antibiotics, and in fact they should not be given until and unless any urological intervention is planned for them. And all these patients especially patients who become bacteremic are the ones who are more immunocompromised, like patients who have diabetes or patients who are on steroids or pre-existing any urological problems, or if they are undergoing any urosurgical procedure. Again, the infection sites, it can happen extraluminal or it can happen intraluminally as well. So the predominant sites is that when site So the site at which the catheter is inserted into the urethra, that's when the bacteria can colonize and enter. The connection sites become and frequent disconnecting when the closed drainage system is not maintained. That also predisposes to catheter associated UTI. And if the level of the catheter is above the bladder, that will also result in reverse flowing and will increase the risk of urinary tract infections. Uh, Anyways, presence of any invasive device increases the risk of infections. And if a patient is having urinary catheter, that also predisposes, because the mechanisms are presence of a biofilm and also presence of catheter per se results in it results in inadequate bladder emptying. So that also may predispose to infections. So if suppose there is a patient who is having a urinary catheter, in those patients, urine routine should not be sent. Why? Because if a patient is catheterized, then the sample from the urine will show pyuria and it will also show RBCs. That is not diagnostics. At the most, urine culture is of more importance, but urine routine should not be sent in patients who are catheterized. And it's very important to prevent the catheter associated UTI, and the UTI bundle predominantly consists of whether, first of all, whether the patient needs a catheter or not. So wherever possible, a U drain should be used. The technique of insertion should be completely aseptic. Ask daily whether this patient needs the catheter or not, or can we remove the catheter. And always an unobstructed urine flow should be maintained. The drainage bag should always be below the bladder level. It should be a closed system. And even if you want to collect the sample, there are catheters which come with a separate port. So rather than disconnecting the catheter, there should be from the separate port, the sample needs to be collected. And this urine sample needs to be collected again aseptically, first before cleaning the site, and then the sample needs to be collected. And of course, whenever all these invasive devices are handled, hand hygiene is of very, very importance. We also have now these Eurometer bags which are available, and this helps in a better measurement. And also these bags have been shown to reduce the risk of the UTIs. Now I'll move on to this case of nosocomial meningitis. This is a patient from Bihar who was a 48-year-old who had a pituitary macroadenoma. And then subsequently, this patient underwent a transnasal transsphenoidal endoscopic surgery. The CT brain showed hematoma just a day after the surgery, for which the lumbar drain was placed. Now, 5 days after placing this lumbar drain, this patient started having severe headache. There was meningismus, altered sensorium. CT scan was done, which showed that there was a hematoma along with some meningeal enhancement and elevated CSF pressures. And from the drain also, purulent drain was was coming out. So the CSF analysis was done, which showed that there was leukocytosis, which was 18,000 with neutrophilic predominance. RBCs were 1,400. Glucose it was just complete hypoglycoria, elevated proteins, and CSF lactate was 144. And remember, more than 4 of CSF lactate is suggestive of pyogenic meningitis. So empirically, this patient was initiated on a combination therapy of meropenem and vancomycin. The CSF gram stain showed that it was GNB, and the culture was positive for the ESBL E. coli. And this particular patient was anyway started on meropenem. With this ESBL E. coli, the vancomycin were cut down, was discontinued. Now, this patient also had this post lumbar drain was placed, which was had to be removed because this was the infected drain. This patient was given meropenem at a dose of 2 grams 8 hourly, but even on this, he was not really improving significantly. He was drowsy and deeply unconscious. However, there were no focal neurological deficits. So which of the following is the most appropriate treatment in this patient? Continue with meropenem with vanco. Meropenem over 30 minutes should be given, or meropenem over prolonged infusions with systemic and intrathecal colistin. Meropenem over 30 minutes with intrathecal colistin. So if there is a ESBL E. coli, carbapenems are the drug of choice. Now at this, because this is a meningitis, and what happens is there are different compartments in the brain. There are intracranial as well as intraspinal compartments, and all these different compartments have different concentration of the antibiotics. And the concentration of the antibiotic into the CSF, it depends upon various factors. It depends upon the lipid solubility, ionization, protein binding, volume of distribution, and generally the beta lactams as such have got a lesser penetration into the brain per se, and that is why meropenem is given at a higher dose of 2 grams 8 hourly. Now, ideally, we would want our AUC by that is the concentration in the CSF equivalent to the concentration to the serum. That is the AUC by AUC in the CSF to AUC by in the serum should be equivalent to 1. Now, when we look at the various antibiotics and their AUC in the CSF to AUC in the serum, as we can see here, the penicillin, cephalosporins, beta-lactams, they all have lesser AUC in the CSF to serum. That is, they have lesser penetration into the meninges. Of course, this the CSF concentration increases when the patient is having meningitis, because that increases the penetration. The other drugs like the quinolones, again, linezolid, they have got good CSF penetration. So this is like 0.7 and 0.9. So linezolid and quinolones have a good CSF penetration, but the other drugs like colistin again and vancomycin have got a poor CSF penetration. So because beta lactams have got a poor CSF penetration, there is at times need for the adjuvant therapy for the treatment of meningitis, and which is local installation of the antibiotics. And a lot of times we can actually use this inhibitory quotient as well, where the CSF drug concentration and the MIC of the organism can be calculated, and ideally this should be 10 to 20%, 10 to 20 for consistent CSF sterilization. So this can be done for certain agents, like for the vancomycin, it can be done. But we don't have this for the beta lactams per se. So if a patient is having ESBL gram negative meningitis, meropenem are the drug of choice. But as there is not much of clinical improvement, intrathecal antibiotics, which can be gentamicin or even colistin, can be used, and these are the doses at which they are used. So colistin is 10 milligrams every 24 hours, or even polymixin B 5 milligrams intrathecally can be used. We also use gentamicin, which is 5 milligrams OD. This is the other treatment option, intrathecally antibiotics along with the systemic carbapenems, which should be 2 grams 8 hourly. And in case of meningitis, these should be given over 30 minutes rather than over prolonged infusions. This is one of the papers regarding the use of which had evaluated the efficacy of intraventricular gentamicin therapy in neurosurgical gram-negative bacillary ventriculitis and meningitis, and which showed that patients who received intraventricular gentamicin therapy had a higher cure rate as well as a lower relapse rate as compared to the IV antibiotics alone. And this was also one of our papers regarding the post-neurosurgical meningitis, which we had presented in ICPIC 2013 in Switzerland. These were the cases of 6 post-neurosurgical meningitis where we had used intrathecal gentamicin as well as colistin for the treatment besides the systemic antibiotic therapy. And in this particular patient who had this ESBL E. coli meningitis, meropenem with intrathecal cholistimethate sodium CMS was used with urgent removal of the infected lumbar drain. The patient improved as well. The other investigations which can help in the diagnosis of nosocomial meningitis is a CSF lactate. Besides the usual battery of tests, CSF lactate should be used, and a lactate concentration of more than 4 is associated with a good negative predictive value as well as a positive predictive value also. Just the limitation is sometimes the levels can be elevated in case of xanthochromic fluids, but if the levels are more than 4, then it has a positive predictive value of close to 96% for the nosocomial meningitis. Serum PCT may show a promise, but this needs to be further evaluated. And we also now have the meningitis encephalitis biofire panel, which detects the various bacteria, including the E. coli as well as E. coli also. But this should be sent in case of a suspected meningitis. But remember that it does not detect the common nosocomial pathogens, like it will not detect Acinetobacter or Pseudomonas and even Enterococcus. So all these can be missed out, and that is why the routine traditional gram stain and cultures are very, very important in the diagnosis of nosocomial meningitis. The take-home message from this case would be that gram stain and cultures are definitely gold standard and are important. CSF lactate helps in differentiating the nosocomial meningitis from aseptic meningitis. Source control, removal of the infected drains, foreign body is very, very important aspect of the management. There's no role of dexamethasone in case of nosocomial meningitis. It is of use in case of Streptococcus pneumoniae meningitis only. And then we have systemic antibiotics as a cornerstone of management, but local intrathecal and intraventricular antibiotics are also adjuvant therapy for the treatment of nosocomial meningitis. So to summarize, it's very important to identify what is the likely syndrome, which are the likely etiological diagnosis, which are the likely bugs, and the rapid initiation of treatment can be definitely life-saving in case of all the infections. It's very important to always look at the good history as well as detailed clinical examination, and we must use newer tests which can be useful for the right diagnosis and early diagnosis, and will definitely help in the antimicrobial stewardship as well as improving the patient outcomes. So there are definitely so many unmet needs, but success comes from working together with the long-term strategy, and it's very important for all clinicians, infectious diseases, as well as the ICU intensivist, as well as the microbiology to work together so that we can bring faster results and accurate results in our clinical practice. Thank you so much.
Thanks, Dr. Neha. Very detailed and lovely information. So can you please stop your share screen?
Yes, of course.
So we'll just wait for any questions. In the meantime, I just wanted to clarify for your audience a couple of things. So you talked about the DPT, right? So the DPT, if it's more than
DTP, no, not DPT, DTP, differential time to positivity.
Yes, sorry.
Yes.
So if it can be more than 2 hours and less than 2 hours, right? So how do you interpret if it's less than 2 hours?
So if it is less than 2 hours, then the diagnostic criteria is not filled. Like the diagnosis of, in my clinical experience, Mostly CRBSI is having a DTP of more than 2 hours. And as for the definitions also, DTP more than 2 hours is CRBSI. But this is not 100%. Sometimes you can get a differential time to positivity of 1.5 also. So the specificity is close to 94% of this particular diagnostic criteria.
So, now just taking that further, supposing you have a bacterium from another source, let's say an intra-abdominal source. Again, both your cultures will be positive, your central line as well as your peripheral line.
Pardon?
See, if you have a bacteremia from another source, then also both your peripheral and central line cultures will be positive, right?
Correct. So here,
How do you make out whether that's a central line infection or?
That is what. So if you have a bacteremia, say from a UTI, so if the DTP is less, then it's not probably the central line. It is maybe a gut-related bacteremia. So
there is a
gut-related or a urinary tract infection. Like it can be UTI with bacteremia. It can be a gut-related bacteremia. Rather, especially in neutropenic patients or even in ICU patients, this is very much possible that line is not the source. It is the gut-related bacteremia which can present as bacteremia and positive culture from both the central line as well as the peripheral percutaneous culture.
Then coming to long-term catheterization, patients in the hospital for months, sometimes in the ICU also. So what kind of recommendation is there for catheterization? Do we go for SPC or change the Foley's intermittently? Like what kind of recommendation is there for this? They get frequent UTIs.
No, so as such, long-term catheters are associated with lesser chances of infections, and normally we keep it for 2 to 3. There is no recommendation to change the catheters like every 3 weeks or so. It's not as such like there are, to my knowledge, there are not clear-cut guidelines on regular changing of the urinary catheters. Normally, if suppose a patient requires a long-term catheter, we tell them to be on the silicone catheters and maintain the hygiene, or not clamp the catheter. These are the simple advices and the other points which are emphasized.
So you like to tell us about what to do with Canada in the urine, because that's another frequent thing. You get Canada on Foley's. So when do we treat these?
Yeah. So just a minute. My son is asking me to open the door. I'll just open it. Just a minute. Hello. So yeah, so if a patient is having urinary catheter in the ICU, it can be, there are two possibilities. It can be the first manifestation. Urinary candiduria can be the first manifestation of candidemia as well, but more commonly, urinary candiduria is a likely colonization, and if it is not to be treated, candiduria is not to be treated until the patient is undergoing some urological intervention or in neutropenic patients. So if the patient is completely asymptomatic, then there is no need to change the catheter also. Like if the patient is asymptomatic, then first of all, the patient does not have to be started on any antifungal therapy, and the decision of changing the catheter is again can be individualized.
And I think you treat the Canada in the urine if there is a neurological abnormality or the patient is neutropenic or immunocompromised. Then you have Canada in the urine if the patient is asymptomatic.
Yeah, if the patient is neutropenic patient, then if there is Candida in the urine, then we have to treat it.
Or if there's instrumentation, or if the
yes, urological intervention, neutropenic patients, and pregnant
And
females.
fluconazole remains the drug of choice, I think. Echinocandins don't go through the urine, so they're good.
Correct. When we talk about the treatment part of it, echinocandins have only 2% urinary concentration and should not be used for the treatment of urinary candiduria. The second thing is we can use fluconazole at a higher dose, especially for the Candida glabrata, because susceptibility is dose dependent. For resistant Candida like Candida auris, combination of flucytosine is another drug which can be used. Flucytosine has excellent urinary concentration, so it can be used for the treatment.
Again, no, in long-term catheterization.
And of course, deoxycholate amphotericin B in case of very, if we are here, we do not have any options.
Is there any role for bladder washes in resistant kind of UTIs or anything? Bladder washes with beta or amphotericin,
No. Earlier it was thought to be, but no, nowadays no.
Last question, we've taken a lot of time. Fosfomycin, the fosfomycin I think has to be done by cross dilution rather than by culture sensitivity. So you'd like to talk about these different techniques in it, broth dilution and e-test and disc diffusion.
Okay, so when we call, I'm not a microbiologist, that's a disclaimer, but yes, broadly, when we do susceptibility, we do it as per the, there are disc diffusion where the antibiotic impregnated discs are placed in the culture plates, and based on the zone diameter, we decide whether the organism is susceptible to the antibiotic or resistant. Then we have broth microdilution or BMD, where typically particular concentration of the bacteria is embedded, and to this antibiotics are added in a graded manner, and the particular tube which shows clearance of the complete clearance, that is taken as the MIC. And now we have, all these are more of little cumbersome processes. We have more easier ones now, which is the automated systems, which just tells, which have typically the, it's more easier. They give us based on the strips, or we can say the GNB susceptibility strips, whatever, they actually give us the susceptibility straight away. I think my terminology can be definitely much better, but as I said that, I'm not a typical microbiologist. I'm an ID with this. Yeah.
So I'll ask, this is a question which has come up, madam. What are various ways to differentiate between colonizer and pathogens? One which I know is colony count, DPT, and clinical correlation.
Okay. So, so there are several parameters which we look into when we have to differentiate between a colonization and a pathogen. First of all, we look at what is the site, right? Whether it's a sterile site or it's a non-sterile site. For example, if it is a sterile site like a blood, it will be more likely considered as a pathogen. But then the second is we have to look at which is the bug which is isolated. So first, sterile site like blood, CSF, or IR guided taps which are done, these are sterile. Whereas urinary, the ET secretions or the TT secretions, these are non-sterile sites. Or a catheter which is in place for more than 24 hours, that is also a non-sterile site. Non-sterile site can be easily colonized. This is one. Second is the pathogen. For example, blood is a sterile site, but if suppose we have cons which is being isolated, diphtherioids, then these are likely skin colonizers. So they can be contamination. But if suppose you have a cons which is isolated, then you have to look into, we have to ask whether the patient has got any invasive devices or not. So if it's a patient who does not have any invasive devices, no history of any intravascular catheters or any mitral replacement, any processes, then in a healthy patient, a blood culture positive with cons is a contamination. But if it's a patient who has got a central line, or it's a patient who's undergoing CKD, undergoing hemodialysis, or a patient who has undergone a mitral valve replacement, in the presence of processes, multiple cultures being isolated is a infection. Then we also have to look into the immune status of the individual. For example, urine culture positive in a diabetic patient can be a asymptomatic candiduria, whereas in a neutropenic patient, in an immunocompromised patient, it will be it has to be treated. It is a more likely, it has to be treated as infection. Again, a patient who's undergone a transplant, for example, a cardiac transplant patient has a sternal site wound and aspergillus is being grown, that will be a significant pathogen rather than a colonization. So it depends upon the immune status of the individual as well. Besides this, we have to look into the radiology. If suppose you have a culture positive, for example, it's a ET secretion, which is positive, and the radiology is completely normal. There are no radiological infiltrates. Then this is a colonizer. Again, radiology, histopathology, they have to be correlated. If there is a culture which is isolated and the histopathology is not showing any invasion, then no necrosis, no invasion, then it will be a colonization. So all these various parameters have to be correlated to differentiate colonization from infection.
So are there any more questions? I hope, Dr. Atul, that answers your question. Any more questions, please? We'll just wait for a couple of minutes. So I think, Dr. Neha, that was wonderful as usual, very informative for all of us, getting ID inputs, in critical care ID is very important, sepsis being the leading cause of mortality. And I think there are no more questions. Till next time then, next lecture. Thank you very much. Take care.
Thank you. Thank you so much, Dr. Tapesh. Thank you and all the best.